that as you guys look at the schedule, you can see that next week we have a couple of lectures and then like this huge lull between my test and my last lecture, right? So we're going to hit some topics, including today, that are kind of like, you guys are going to be like, well, how do I differentiate between these neurological assessments and these neurological conditions, okay, these pathologies? So if the need arises that either A, you want to have like a supplemental period of instruction, right? So completely, again, something that I will ask if AC, that kind of coordinator, to kind of put in your schedule, that's fine. Or if you want to do small group stuff and we can coordinate outside of class, that's fine too. Okay, but you guys know that my door is always open, right? My phone is always on, right? So if you text me with questions and you want to meet up, or just have me answer your question. No, I don't know the answers to the farm test. Okay, so there you go. I took away her question.
DMARDs are on
What's that?
there. DMARDs are on there.
DMARDs are on there. So you notice how I was just talking to a student about that, and I am rambling. I'll start here in a second. But that's the reason I don't get into the specific stuff about the medications, because you guys get tested on that elsewhere, correct? So it's just important to understand when I'm talking about certain pathologies that you need to know where they apply, correct? Okay, so it's kind of a double dip, if you will. But I try not to, hammer down on those things because you guys get hammered enough in other courses about other medications that I don't necessarily talk about. So, all right. So we're going to finish up with thoracic outlet syndrome today. Okay. So my voice is still cracking. Apparently I'm still going through puberty. But I'm fighting the iPad bump. So hopefully my voice doesn't crackle too much. But if you have a hard time understanding something, just do what Lieutenant Bandy does and just get my attention. All right. So thoracic outlet syndrome. The important thing to understand about TOS, right? TOS, not POS. TOS. Okay, is that it is not brachial plexopathy, correct?
Yes.
The answer is yes. Okay, because this involves the narrow space between the superior shoulder girdle and what? The first rib. Okay? So you can see that blow up there in the bottom right. That shows you exactly what that's describing. Okay, so that's where the nerve dives underneath the first rib, correct? Superior shoulder girdle being the clavicle, right? So that's the superior shoulder girdle. Okay? So again, when you start talking about these pathologies, and you guys are taking tests, specifically my test, and then moving on to pants, read the question. Because if it tells you there's pain in a certain region, and you can just differentiate between the, mechanism of injury, right? So if there's a mechanism of injury where they got hit by the crown of a football helmet, you're probably talking about brachial plexopathy, right? The answer is yes. Okay, but if you're talking about something that's kind of been long-standing and intermittent, then you should lean more towards TOS, okay? So women, 20 to 50 years old, okay? That's kind of what your book says. So but it can be variable. Do men get this? Yes. It's just telling you what the most common is, okay? So again, women, 20 to 50 years old is most common. It's in yellow. So secondary to congenital abnormalities, specifically that's that cervical rib. Okay, so let's go back to our discussion about anatomy and MSK radiology. Does C7 have a rib? In this case, the answer is no. Okay, unless that's the cause of TOS, for example. Okay, so that's something that's different. Transverse processes, okay, that's not as common, right? But you can just say it's a long process of C7 and not necessarily a whole rib. Okay, and I'll show you a picture here shortly that'll differentiate that. And an anomalous fibromuscular band. Okay, that's just where congenitally they were, they came out of the womb and they had an anomaly where the fibromuscular bands are thickened. Okay, and that causes that compression. Is this still compression? It is, right? It's just compression in that space as it dives underneath the first, the shoulder girdle and the first rib, okay? Between, right? So, post-traumatic causes, if there's a history of trauma, it's just basically a result sometimes of scar tissue formation. So that's fibrosis of the scaly musculature, posterior sternoclavicular dislocations. Did you guys talk at all in radiology about ST dislocations? Sternoclavicular? Okay. But you do understand that that's close to your sternum, right? As the nomenclature denotes. So do you think that if the sternoclavicular is depressing posteriorly, that it's going to hit certain anatomical locations, right? So it puts you at risk for that. So just understand this is another thing. You can also have some vascular changes, correct? The answer is yes. Okay, that's the first time you're hearing it. So, widely displaced AC injuries. Again, remember when we talked about AC injuries, we talked about if the picture just doesn't fit, right? Because they should have pain at the AC joint, correct? Should they have a lot of distal neurological symptoms though? No. Most of their pain should be confined to the AC joint. So if they do have this kind of weird neurological picture, then maybe you need to explore whether or not they have post-traumatic cause of TOS, thoracic outlet syndrome. Okay, are we good with that? Okay, and pregnancy. Pregnancy, I've never seen it. I've never once seen a pregnant female with TOS. So it exists. I put it on there because the book mentions it. So I don't want you guys to miss out on that nugget in case pants decides to get tricky. Okay, so neurologic symptoms, diffuse, non-specific complaints of the entire upper extremity. So this is not dermatomal necessarily, correct? Just kind of this weird, vague, distributive symptoms. Okay? Mimics ulnar neuropathy symptoms. So it's important to understand that it is upper extremity, correct? So it can go out to the fingertips. Okay, so understanding that the difference between ulnar neuropathy and this is going to be important. Make sense? So can you have ulnar neuropathy in brachial plexus injuries? You can. So again, it's still in your differential. Okay. Most patients will report an aching, pain, and paresthesias from the neck into the shoulder, arm, medial forearm, and fingers. That's all your nerve distributions, correct? We learned about those neck last block. Yes, we did. Yeah, I know because I tested you on it. Okay. Vascular, this is the one. Okay, vascular. This is usually kind of how PANS tries to say, well, we're going to give you a question that it really could only be TOS, right? That's that vascular, those vascular changes like intermittent swelling, discoloration, and what? Aching, fatigue, and weakness. Okay. You guys did learn about Raynaud's disease, correct?
Yeah.
Yeah. So you know that people that smoke are predisposed to that, right? Peripheral vascular constriction, things like that. So that should be part of your differential too. Sometimes it's just Raynaud's, or sometimes it's TOS with Raynaud-like symptoms. Make sense? Okay, so these are your special exams. The one at the bottom there, I put there as an FYI. It's not testable. It's not even mentioned in the book, which is really weird because it's a good test, okay? Especially if you're kind of stuck on, is this TOS? But the Rouge test is fair game, right? So that's also called the elevated arm test, right? Okay, so when you guys are doing your physical exams, another thing to understand is, remember we talked about those anomalous congenital or post-traumatic changes? So you're going to palpate what fossa? The supraclavicular fossa, right? The supraclavicular fossa is literally above the clavicle. That depression that you feel, yes, Angela, keep doing it. All right, keep finding it, right? So it's right there. So if you feel a mass there or some kind of fibrous tissue like feel, then that could be a cause, correct? So auscultate for bruits, especially during provocative maneuvers. And again, that's why I put the absence test on there, because that's what you're doing, sort of. You know, when you're doing absence test, there's a bunch of variations of it where you listen for bruits. Okay, so if you want to look up absence, I will mention it during the lab next week as well. Okay, I think it's that important. Comparing pulses between both sides. Again, that tends to lend itself towards the absence test because that's literally what you're doing in an absence test. But if you just feel a change in pulses, right, not an absence, but just a change, then that can be indicative of TOS. Because as we look at this picture before, it's not just nerves running under there, right? There's an artery there, there's a vein there, things like that. Okay, other structures. Okay, so important to again assess pulses, right, bilaterally. You don't agree, Brown? Oh, okay, got you. Just wanted to make sure. So compare distal nerve, sensory, and motor function. What's the most important one? Ulnar, right? So ulnar. Make sure you check that, because if you don't, you'll miss potentially brachial plexopathy. Okay? Make sense? Okay, Ruse test, again, elevated arm test. That picture in the top right there shows you, okay, not only are they abducted 90 degrees, they start in this position like this, right? I surrender, okay? And you have them open and close their hands real quickly, right? How long do you do that test? 3 minutes, right? So the video that you guys have on your site, I have to find a model and redo them because it says like 60 seconds or something, but it's 3 minutes, okay? So at some point, as you're staring into your patient's eyes, right? 3 minutes is a long time, right? You have them say, okay, now elevate your arms and keep doing it, okay? And you'll notice if it's pretty severe pathology, especially that not only is it come on pretty quick in this position, right? As you start to elevate, it gets worse. Make sense? Okay, so again, that's why the Ruse is sometimes called the elevated arm stress test, okay? Reproduction of neurologic or vascular symptoms is a positive test, right? So don't miss that, and or, okay? So if they have the vascular changes, it's also indicative. It may not be necessarily compressing on the nerve as much as it's compressing on the vasculature. We good with that? Okay, so imaging wise, you see the arrows there, okay? I blew up the pictures for you guys, so, well, A, so I could see it, because, you know, I wear glasses. But I was like, man, those are really small pictures. But you guys can see where the arrows are there. That's C7, and the top one looks like it's just a long transverse process, or it looks like another rib. It looks like another rib, right? And the bottom one just looks like a long transverse process. Would everybody agree? Okay, so that's kind of your differences there. But it's just understanding those are anatomical variances. That's not due to trauma. That's a congenital abnormality. Okay, so when you get your X-rays, that's what you're going to see. So of course you're going to get X-rays, right? Yes. And then since they have symptoms in and around the shoulder, you're going to get radiographs of the shoulders, especially if there's shoulder symptoms. Differentiate. Chest X-ray, does this sometimes that anomalous mass, right, in the supraclavicular fossa, could that be a tumor? Could it be a tumor that's compressing on a nerve elsewhere as well that's not palpable? Absolutely. So chest X-ray kind of tends to be a standard that we get as well, okay? MRI of C-spine, you're going to get that only if this rule still applies, right? Only if they have significant neurologic symptoms or the clinical picture is unclear. You get your X-rays, you don't see anything, okay? You do your physical exam, you don't find anything. But they're still having these symptoms, so you would get an MRI of C-spine, okay? Just like with anything that has neurologic symptoms and or weakness, okay? You can do an electromyogram and nerve conduction study. You should do those together, okay? And should you do it bilaterally or unilaterally? Bilaterally, right? Compare it to the unaffected side, okay? And that's especially important if you're kind of like, well, again, is the nerve compression or entrapment is another word, okay? Entrapment tends to denote a canal. We talked about guyos yesterday, right? We'll get into more of that. But you're just trying to find out is there nerve compression somewhere. So if you do this because you think that there are peripheral nerve, ulnar nerve entrapment, excuse me, then that can help you differentiate. Are we good with that? Adverse outcomes of disease, obviously weakness and or loss of coordination. So very commonly with upper extremity or hand pathologies, I'll ask patients, do you have trouble turning doorknobs? Do you have trouble with the steering wheel? Things like that, right? Just to see if they have any loss of coordination and or weakness. Chronic headaches, okay, obviously anytime you have chronic pain, you can have chronic headaches, right? So loss of overhead range of motion, so if it's painful for them to elevate their arms, they're going to stop doing those activities. So therefore, over time, they can develop stiffness, correct? And that's the enemy of orthopedics, but that's something you may see, okay? So what's the treatment? There's a bunch of stuff there, right? What's the only thing highlighted in yellow? PT and avoidance. If you just remember as avoidance, you find precipitating or aggravating factors, and you tell the patient to avoid those things, okay? Depending on what service the patient is in, you may have to give them a pretty lengthy profile, correct? Kind of addressing certain things, so make sure you do that, okay? The rest of it's the same, It says rice, conservative care, right? Proper posture and weight loss. Obviously, if there's compression there due to expansion of mass, I'll leave it at that, right? Then encouraging to have weight loss can help with their symptoms. With some patients, it may actually relieve all their symptoms. So muscle relaxants, all right, you guys know every single muscle relaxant now. You know all the names, generic and trade, right? And you know all the dosages, okay? Yes, Angela's saying yes, okay? So TENS, so that's that transcutaneous electrical nerve stimulation. Okay, that's trying to do basically to take their body from recognizing that that pain stimuli and create white noise, if you will. Try to lessen the patient's perception of that pain. Okay, but it can also help decrease the severity of symptoms. So obviously, if you have a cervical rib, okay, or a anomalous transverse process, can you go in there and just shave that down? Yeah. Does ortho do that? No. We don't operate in kill box. Okay. We tend to stay away from the trachea and the center mass. Okay. So, but it's just thrown in here again because it's MSK related. Okay. But usually we'll try all the non-operative treatment, everything listed there, and then some. Okay. You can use your capsaicin creams and all that craziness. Okay. What's the other one you guys like? Diclofenac gel, right? Yeah, you love it. Okay. But just understand that first outcomes of treatment, right, regardless of what they have, okay, some patients will go on to develop cramps. We already learned about that, right? Cramps is weird. Right? Cramps is one of those things where you often have to search for multiple causes or multiple contributing factors. So don't lose sight of that, okay? Intercostal neuroma, anytime you do surgery in and around a nerve, the nerve can basically thicken as well, right, and create a neuroma. So that's something you could get, okay? So pros and shoulder, we know that already, right? So adhesive capsulitis, the glute shoulder, if you will, okay, so that can develop as well, okay? Brachial plexus injury, always going to be in that differential, but a lot of times if you go on to treat it, can you cause a plexus tissue? You can. That's why we don't do those surgeries, okay? That's neurosurgery or cardiothoracic, okay? And pneumothorax. So obviously, you know that the apical portion of the lung is pretty high up, right? It's higher up than you think. Some people puncture lungs just doing acupuncture, right? So it's possible. Make sense? Okay. So red flags, obviously if you're having significant neurovascular changes, refer. You get your x-rays, as you always do, and you see those anatomical variances, you refer. Okay? And what's the one that's in yellow? Not everything you can do, so now you gotta send it to someone else. Okay? Any questions about TOS? Seems easy, right? Wait till I give you questions and ask you, is it TOS or is it brachial plexus? Then you're like, man, this sucks. Okay? I'll try to give you guys some questions earlier this time. That way you can kind of start getting the mental process going. Okay? You guys okay with that? Neonatal brachial plexus, bless you. Neonatal brachial plexus, so when you talk about neonatal, we're talking about like around birth, right? Read the question. If it's around birth, you're going right to this, okay? And then you're deciding if it's one of the ones I'm about to talk to. Good to go? So is it still upper extremity? Yeah, upper extremity and sensory deficits. Most common is which one? Erb's palsy, right? I gave you the percentages. I added them there. 50% is Erb's palsy. That is C5, C6. Okay? Weakness of elbow flexion, shoulder abduction, flexion, and external rotation. Okay? You see that picture there? Is that what that picture is showing? Yes. Abduction. Elbow flexion is not there. That's fine. But is it there?
Yes.
Okay. Weakness of elbow flexion. Okay. All right. So we'll get to that here in a second. But the other one that's more common, but not as common, right, is what percent? 30%, right? Is Klumpke's palsy, or clunky palsy, or clunk, I don't know how you say it. So, but that one is C8 and T1, right? So that one affects the hand and wrist. So do you have all those other symptoms, like the shoulder abduction with that?
Yeah.
You just have the hand and the wrist symptoms, okay? Panplexus palsy, so that term panplexus, meaning you guys have probably learned about pancostal tumors and things like that, right? So it involves the entire plexus, okay? So those are only 20% of the cases, okay? So again, discussing poor prognosis factors, entire plexus is involved, Horner syndrome, and nerve root avulsion. Is this the same thing as we talked about preganglionic with that nerve root avulsion?
Yes.
Yes, so that rule still applies, correct? So a poor prognostic factor. Okay, good to go? So this is caused by the birthing process. That's the difference with this, okay? That stretch is caused during the birthing process, okay? You good with that?
Yeah.
So when we get on to moving on to that description of that position, you see this position here? Okay? This is your, what does it describe there? Shoulder abduction, flexion, external rotation. Okay? See that? So do you think that's a picture you want to kind of burn in your brain?
Yes.
Probably, right? So you see that. But basically, the big thing about that, sometimes you won't see necessarily the abduction right here, but the pseudoparalysis is something you will see. There's a loss of nerve function, correct? So they have that pseudoparalysis. Okay, so when you look at them, in this case of this picture, they're moving their arm, their right arm, excuse me, freely, but their left arm is kind of stuck in this position. Okay, so that's pseudoparalysis. If you see discomfort or irritability, especially if it's significant, then you want to start thinking to yourself, well, when they were born, yeah, they had the plexus issue, right? They had that traction, but did they also sustain a clavicle fracture or a humerus fracture? Okay, sometimes with deliveries that don't go as planned, they use instrumentation to get the baby out, right? Right? They do different techniques and different maneuvers, so it could cause fractures. So that's something that's very common with the workup for that. Okay? Are we okay with this description of the position? Okay. All right. So here's another description here. Okay. So, you know what? That is written wrong. Yes. So it's adduction, correct? Okay. I apologize for that. That's a typo I didn't catch. So it's shoulder adduction, right? But when you look at the picture there, what's the big thing? Because they may not have necessarily the shoulder adduction. The arms, it may just be out to the side. But the internal rotation is always going to be there. The forearm's going to be, the elbow's going to be extended, and the forearm is going to be pronated, and the wrist is going to be flexed, okay? So even if the arm is a little bit out to the side, you'll still see this position, essentially, is what I'm saying. Make sense? Because the baby's just going to, it's pseudoparalysis, right? If they move the baby in the incubator, or whatever the baby's in when you're examining them, the arm may be in a position that someone put them in. But that internal rotation will always be there, okay? And also that wrist flexion, okay? So when you're deciding whether or not it's preganglionic and postganglionic, that is going to be something that is going to be prognostic, correct?
Yes.
Most patients that have Ehr's palsy go on to have a full recovery. Okay, so this is the best prognosis. Which one has the best prognosis?
Ehr's palsy.
Perfect. Okay, so as with any other neurological condition, is it going to be important to do serial neurologic assessments?
Yes.
Yes. So that's why that's there. Okay. I apologize for that typo. That's a bad way to go. So radiographs, again, you want to get them if it suggests that there's a clavicle or a humerus fracture. So has anybody heard the term babygram? Babies are small, right? Can you put a baby on a plate, an X-ray plate? You guys know what an X-ray plate is? Literally the plate, that thing that they put your extremity on. But you can put the baby on that plate, the whole baby. Okay. So it's called a babygram. Okay. So a betagram we get very often if there's a concern for, like, unfortunately, for non-accidental trauma, right? Abuse, okay? So betagram is a term you'll probably hear in the ER, right? So again, this is something where it's neurological in nature. So can you get nerve conduction studies?
Yeah.
Yes. Okay, and that may help guide you in not only in deciding what the diagnosis is, but also for guiding treatment depending on their improvement. Okay? And if it's bad enough, it can also help you decide what kind of surgery, excuse me, it can help you decide if surgery is even indicated and what kind of surgery is indicated. Okay? Are we good with that definition? All right, so moving on to treatments, non-operative, that's going to be the mainstay for Ehr's palsy, correct? Because that has a really good prognosis, all right? But it's important to do serial monitoring of nerve function just to gauge recovery, okay? Other thing is you want to understand that since these patients have this condition, they're not moving the extremity, correct? Can stiffness therefore set in?
Yes.
What's the enemy of orthopedics?
Stiffness.
Stiffness, and I'll add a layer to that. If you have stiffness in a certain position, do you think that the muscles and tendons want to tighten up because they're not moving?
Yes.
Well, then you get contractures. Okay, so contractures are bad, right? So we want to avoid the development of contractures. Okay, so and that's just passive range of motion, and I'll show you a picture here about some other physical therapy for pediatric patients. But is this a subspecialty within physical therapy? Yes, it is. Okay, so pediatric physical therapy, a lot of times if you're working at like children's centers or pediatric focused hospitals, they'll have these specialists on staff. If you guys are out there in the sticks, you may have to refer patients. Okay, so just understand your referral capabilities. Operative microsurgical reconstruction. That's small structures in a very small area, right? So that's something that's going to be done by specialists, right? Pediatric neurosurgeons. So we already took a specialty that is super specialized, and now we added pediatric to it. So do you think those specialists exist everywhere? No. So again, this is something you're going to have to jump on pretty quick. So, and then surgery to address imbalance of the upper extremity as needed. Right? So, for example, if you have contractures, you might have to do releases, right? So sometimes when we're out there, we're doing humanitarian missions, we run into these patients. I was on the USNS Comfort, right? We're out there floating around, right? Drunk sailors. And you go into port and you go see patients, right? And we find these patients, these contractures, and we medevac them on the ship, and we perform these releases. Okay, to give them a better chance of recovering from that condition with limited complications. Okay. So referral decisions. So we know that when a child is born, they do an immediate assessment, right? We also know, or will know, right, at some point, that in pediatrics they also do a 24-hour assessment. Okay, so if these conditions are found, that's when you want to find them. Okay. So another red flag if you're concerned about sepsis. So for whatever reason, the clinical picture seems to be something more of an infectious nature, especially if it seems to be systemic. That's a referral. And then the other thing is, like I just discussed, non-accidental trauma, NAT. That's a way that we write in a chart where we don't use the word abuse, right? But non-accidental trauma means that it wasn't an actual trauma caused by some kind of a fall. It's abuse. Okay, so if the clinical picture doesn't make sense, right? We got bruises of different stages of healing, just doesn't make sense, right? We'll talk a little bit more in other courses about how certain fractures don't exist in kids that don't walk, right? So if you see those fractures, you should be concerned. Make sense? So for now, though, it's just sudden loss of function of an extremity that didn't exist when you assessed them at birth. Make sense? Okay. So torticollis, by definition, torticollis is a spasm, right? So it's a tightening, it's a contraction. Okay? So We already talked about that contracture a minute ago about what it is, but this is something that is either congenital or acquired. Okay, so go ahead and start thinking of it in those terms when you start thinking about torticollis. So when we're talking about torticollis, lateral bending to one side, but rotation to the other side. So the example I gave you to make it consistent with the picture you're giving is bending to the left and looking to the right. Okay? So that is CMT, congenital muscular torticollis. Okay? Unilateral, is it bilateral? No, it's unilateral. Sternocleidomastoid SCM contracture diagnosed after birth. Again, I told you that this is around birth, correct? So when you're thinking about these conditions, these two I'm discussing now, and the different types of each, think about it as, okay, this was due to birth. So if you see a pants question that sets you up that way, that should be a short list in your differential, right? So you're not thinking all these other things. Make sense? Of course it does. So acquired, so it wasn't present at birth, and it developed later in infancy or in childhood. Okay, so they come to a well child check 2 months after birth, and now they have torticollis. Is that congenital? No, that's acquired, okay, by definition. So later in infancy or childhood, it can have involvement of the eyes, nystagmus, superior oblique palsies. You guys talk about nystagmus in neuro, right? Yeah, so we all know that that's the movement, correct? Okay, so a couple of ticks are normal, but a lot of ticks is not good, right? So when it comes to spine, I know you thought you were done with spine, right? So, but remember that lanto-axial relationship, C1 and C2? Okay, so here it comes again, but that's a rotary displacement, correct? So that's AARD. That's what that is, okay? So that's what's causing an abnormal appearance, and therefore, since you're not having normal motion, then you can have a contraction. It can also be due to trauma, infections, and neoplasms. So if you think for acquired, it already sounds like it's going to be kind of a more involved workup. A lot of imaging, right? A lot of subspecialty referrals. Guess what's coming next, right? The last thing I'll mention is congenital cervical spinal anomalies. I don't know how much of this is going to help you because, again, can kids get all kinds of weird congenital anomalies? Yes. Okay, so again, I'm going to go ahead and put it out there. Focus on congenital versus acquired. Okay? Because all that congenital cervical spinal anomaly stuff should be found due to abnormal findings in those exams that we talked about, done at birth and done at 24 hours and prior to discharge and things of that nature. Okay? But that's when you get into all that stuff about congenital scoliosis at the cervical thoracic junction, anomaly at the occipital cervical junction. It's like, what does all that mean? There's a lot there. Okay? So I want you guys to focus on the congenital versus the acquired. Right? Unless you want another question on the test now. And then I can give you 53. Okay. All right. So congenital muscular torticollis. Look at that picture there. The head is tilted which way again? Back. Okay. It's always the patient's, right? Okay. Head is tilted left, and you're looking right. Okay. So it says they're bending left, looking right. So that's called the Cock-Robin appearance. And there's another picture of it there, called the Cock-Robin appearance. So if you see that in a study guide somewhere, right, when you guys are cramming for pants, right, or for my review test, and you see all these buzzwords, that's what that means. That's head position and the turning of the head that I just described, that's sometimes called the Cock-Robin. Okay? So again, using that example, I've tried to stay consistent. There's a left tilt and a right turn. Okay? So the ARDS, A-A-R-D, is that acquired? Yes. Okay? So that's different. How is that different? The tilt is the same side, or it's the spasms on, excuse me, the tilt and the spasm are on the same side or opposite sides?
Opposite.
Opposites, right? So when you read the scenario in a few weeks, make sure you look and see which way the tilt and the spasm is. Okay, because if they're opposite, then which one is it?
Required.
Required, correct? Okay. So again, complete neurologic assessment. Does it involve the eyes? Yes. Who's the eye doctor? An ophthalmologist, correct? So detailed specialty, ophthalmologic goal. Yes. Exam is indicated. Okay. Complete MSK. Don't worry too much about the DDH for now. Developmental dysplasia of the hip. You guys will have all kinds of fun with that next block. Okay. We'll get into that deep. But just understand that patients that have torticollis tend to have DDH as well, developmental dysplasia of the hip. And intrauterine deformations can occur. Okay, and again, that gets into that anomalous conditions that I was talking to you about that I'm not necessarily going to require you guys to get too deep into. Okay, good to go? Unless you want 54 questions. Okay, so imaging-wise, you're going to get that for all forms of acquired torticollis. So what's the initial management for a patient that presents with acquired torticollis? Get x-rays, okay? Trying to see what's going on, okay? So the arrows there denote some abnormalities there. Okay, can you see the subluxation of these bodies there on this left-hand picture?
Yes.
You can, right? Because you guys are experts now at slippage, right? Right? But the one on the left looks like there's some, is that supposed to be, let's see if it works. It's supposed to be over here, or is that normal?
No.
That looks weird, right? It looks like a chiclet got stuck in the middle there. And so that's not normal. So that's what you're looking for. You're looking for any underlying congenital bony abnormality, okay? And MRI, the rule still applies. Anytime there's neurological symptoms, especially if they're unexplained, then you want to make sure you get an MRI. Okay, good to go? So treatment-wise, this is some example of some physical therapy maneuvers. Do you think that when the parents take the patient to the therapist and they have their first session, that the therapist says, okay, now you've seen how I do it, you're going to do this every day, 5 or 6 times a day? And then the parents are like, ooh, me? Especially if they're first-time parents, right? So they can be kind of scary. But just make sure if you're seeing them in follow-up that they're doing it. Because why? Because in congenital, what's the percentage of patients that will improve with just the physical therapy?
90%.
90%. I mean, that's huge, right? Only 10% to go on to need further subspecialty care. So make sure they're compliant with the therapy. If they don't remember the exercise, and how do you confirm that they know how to do the exercises? Show me. That's exactly right. Same thing with a soldier or Marine who comes and says, I've been doing my PT, doc. And I'm like, oh yeah? Show me your exercise, and they can't. And I'm like, you're a liar. Okay? That's one way you can just cut right to the chase and be like, nope, you're lying. Don't call them a liar to the face. Uncharted. Okay? So acquired depends on underlying etiology. I'm not going to go down that road of like, oh, okay, we do this for that. Again, that's getting into subspecialty stuff, and I just don't think that's time well spent for you guys, okay? If you want to talk about it after class, that's fine. If you have trouble sleeping, I'll send you some articles. Okay, so operative, all acquired, right? Operative, at least evaluation is going to be for all acquired. Okay, what's in yellow there? Right, so that's at 10%, correct? 10% doesn't show improvement within how many months? 12 to 18, then you're going to refer them. Good to go? If they're, let me clarify that again, because I discussed this in other topics. What do I mean by improvement? Not improved, right? It's like adhesive capsulitis. They're showing improvement, therefore you stay the course. Make sense? That's all I'm saying. It doesn't mean they're improved at 12 months, or 14 months, or 16 months. It just means that they're improving. Make sense? Yes, sir.
Probably jumping ahead, with the non-improving, they're so young, how long would you, or how old can they be until you like surgically intervene with that kind of stuff?
For acquired or for general?
Congenital.
That's a good question. So the thing about that is, would you agree that, again, we discussed how, I'm sorry, his question was for congenital, right? Okay, we're talking about congenital. How long can you wait to see improvement, okay? Now, remember, this is a contracture, right? It's a spasm, contracture, it's stuck in the locked position. So does stiffness set in? Yes. Does neurological compromise set in?
Yes.
Is serial neurological assessments important?
Yes.
So if you see during your serial neurological assessments that they're not improving or seem to be worsening to a certain degree, right, then you will consider sending them for surgical evaluation. Does that mean they're going to get surgery? And I clarified this before.
No.
It's a consult, right? So even if you send them to me, for example, no, you would never send them to me. But let's say that someone made the mistake of sending them to me, right? Then they go to a pediatric orthopedist, okay? And the pediatric orthopedist looked at him and said, hey, what in the world is going on here? He's getting better, right? That's okay, right? It's still non-operative management in an operative arena. Okay, did I answer your question?
Yes.
At some point? Yeah. Okay, so red flags again. I mean, I just put the referral guidelines there just for the PT aspect of it. So referral for, should at the minimum be physical therapy, correct? Probably a pediatrician too, okay? All patients required. Any patient with head tilt and rotation to the same side. So what does that mean? Head tilt and rotations to the same side. Can we talk about how that's not CMT? Right? So there you go. That just sums it up again. Your book is a little confusing and I'm not sure what they're getting at, but it's word for word. So, all right, so these are the conditions we talked about. Notice that it took some time, right? And I waited to discuss these today because these are the ones that people trip up because they see everything as TOS and they see everything as neonatal brachial plexopathy, torticollis, and then you have to look for those differentiators, okay? Make sense? And do kids get TOS?
Yes.
No. 20 to 50-year-olds, right? You're welcome. Okay. You got it? A little bit kind of sarcastic, more than I am normally. But please, God, don't choose that, okay? I appreciate you. Let's come back to the top of the hour. There they are. Okay. All right, just to go back real quick, I appreciate OT Roat, right? Okay. Pointing it out, the slides are actually correct, probably because I corrected them. So one is showing the motion, right? So the lack of abduction, right? And the other one's showing the position. Make sense? So this one over here is showing the position right there. Okay, so that's the waiter's tip position. Okay? So, sir. So if I'm walking around, right, and I get right about here, and I'm like, man, I think I'm measuring really good. Okay, and I deserve a tip. All right? I'm just like this. And that demonstrates, there's nobody right here, so I have to go a little closer. But that demonstrates the waiter's tip position. Does that make sense? So again, if I go to Mr. Ram and I say, hey, give me a tip, right? Right? It's not going to help you on the farm test, but I deserve one. Okay? So that's where that waiter's tip position comes from. Good to go? The horse has been beat to death. So hopefully you don't forget it. Okay? So, moving on. Oh wait, question? Question marks? Does anybody have any questions? No, seriously. After the break? Okay. No? All right, so now, oh, yes.
So you're saying that's the position,
Yes.
but you're saying the first description?
Is just saying what they have, when it says the weakness and abduction, right, that means that they're not able to move the arm away from midline.
And also says flexion and external rotation.
Yes, so the arm is stuck, the arm is extended, correct? The waiter's tip, so they're unable to flex the arm, the elbow. Make sense?
Why would it not be internal?
It's still internal rotation, but it's the elbow flexion.
It says external.
Yes, so they're stuck in internal rotation. So when you're describing what they're unable to do versus the position that they're found in, they're opposites.
Alright, so this is just what they're unable.
Correct. Okay, we good? Okay, your book does say some things confusingly. That's not a word. So I try to clarify them, right? But just understand that that's saying that what they're unable to do. Right? Do you look at a neonatal patient and tell them, I want you to flex at the elbow? No. Right? But that's just saying if you're describing it in orthopedic terminology, that is what they're unable to do. And then the position that you find them in is the later tip position. Did I answer your question? Okay, good. I want to make sure that's clear. But nothing worse than lecturing for me. All right? I'll find out at the end of the semester in my critiques. So when we talk about the topics that we talked about, which one of these topics are you most concerned about differentiating between? Thoracic, again, versus brachial plexus, and if it's neonatal, then deciding which one it is most commonly, right? And then the last one is torticollis. That kind of goes on its own. Okay, do adults sometimes get torticollis? Possible, correct? Lockjaw, things like that. But we don't discuss that. So don't throw that in the mix. Okay? Good? All right, we do have to move on. All right, so elbow pathology. So now we're transitioning to a whole other thought process. That's the reason yesterday's lab hopefully was beneficial for you guys, because we're gonna hit a little, we're gonna turn on the afterburner a little bit. Okay? If I'm going too fast, stop me. But again, some of this is repetitive. Epicondylitis, but people have probably already heard the terms tennis elbow and golfer's elbow, or bowler's elbow, okay? We don't really use that in orthopedics. We describe pathology based on anatomical structures and again, the physical exam findings, correct? The answer is yes. Okay, so lateral epicondylitis by definition, yes, it is tennis elbow, okay? Would I give you a question that says the patient has tennis elbow? No. No, I would say lateral epicondylitis. Right? We don't talk like that. Okay? So where is the pain at? At the lateral epicondyle. Okay, so we would agree that the lateral epicondyle, it is fair game to talk about the elbow in terms of medial and lateral, correct? And so therefore, though, when we start getting closer to the wrist and hand, then we transition to ulnar and radial, for the most part. Of course, we'll find an exception in the lectures coming up shortly, just to confuse us, okay? But where's the origin? We did discuss yesterday that the lateral epicondyle is the extensors, right? So that is the origin of the ECRB, the extensor carpi radialis brevis muscle, okay? So that's what you need to know. See the box there? That's the ECRB origin, okay? So when we talk about lateral epicondylitis, that is the most common one. The most common one is lateral epicondylitis. What's the age group that usually falls under? 30 to 50 years old. Okay, we had another condition earlier that was, what, TOS? That was 20 to 50 years old, right? Yes? Yes, okay, the answer is yes. So just understand that this can occur a little bit later, okay? And so when we're talking about lateral epicondylitis, that's the gradual onset of pain in the lateral elbow. That's kind of how you're going to see it written out. Is that how you're going to see it in clinical practice? Not necessarily. Can they have a history of trauma and have pain at the origin? Of course, right? If you ding something, it can hurt. But in a true PANTS fashion, they'll usually ask you questions talking about a gradual onset or a progressively worsening is another way to say it. Okay? After some kind of event. Usually some kind of overuse or repetitive motion event. Good to go? So gripping and wrist extension activities worsen their symptoms. So do you think you're going to ask them if they have trouble gripping things and doing activities that cause wrist extension? Yes. Where are my tennis players at? Not a one? No one wants to admit it. Pickleball. Everybody will admit to pickleball because that you can have other activities with pickleball, right? So I can't say only. But so you would understand that tennis play, right? There's a backswing and a forward swing, correct? So that's how they're going to describe it. They're going to say though that the most of their pain is in wrist extension, correct? And they're going to also describe to you that they have trouble lifting, turning a screwdriver, and in the backstroke of a tennis racket again. Okay, any questions about that? We talked about this test yesterday, right? Okay? Yes, we did, right? So we differentiated that. So when you have the elbow flexed 90 degrees at the patient's side, and you tell them to extend their wrist against extension, they shouldn't have pain on the lateral aspect of the elbow, otherwise known as the lateral condyle, right? This is specific to this condition. So that's your test, okay? So what's in yellow there? Lateral and 1 centimeter distal to the joint. Okay, does it necessarily have to be right over the epicondyle? No. It could be upwards of 1 centimeter distal to the epicondyle. Pause for effect. Okay? All right. So now we're talking about medial epicondylitis. Switch gears. Okay, now we're talking about the medial aspect of the elbow. Okay, so when we talk about medial epicondylitis, again, that's golfer's or bowler's elbow. I have heard golfers, I've never heard anybody refer to as bowler's elbow. Any big bowlers in here? Nobody admits anything. So, but that's the pain is at the medial epicondyle. So literally on a physical exam, you ask them, point to me with one finger, where does it hurt the most? And then can the pain be a little bit kind of vague sometimes, because that's the common, right? Pay attention there. Common tendinous origin of the flexor and pronator muscles. So it's not just one, correct? It's the common, so there can be multiple, correct? Flexors and pronators. Make sense? Somebody says so. But it's less common than lateral, right? So what's the one that they're usually going to ask you about? Lateral epicondylitis, correct? So when we talk about this, pain with active what? And prone pronation. Okay, so pay attention to the scenario you're given, right? So I don't want to beat that to death. And the test is obviously the opposite, correct? You rotate the arm, right? So palm up this time, and you have them flex against resistance. And that reproduces their pain at or about the lateral epicondyle, the medial epicondyle. Okay? Can it be distal to the medial epicondyle? Can be. Okay, so I don't want you guys to get confused about that because I'm going to talk about something else soon. Okay. So radiographs again, usually when you get radiographs, they're going to be normal, especially if there's a history of trauma. Okay, but you still get them. Why? Because if you do find something, then the treatment changes. Okay, so but you're going to rule out OA, osteoarthritis, or osteochondral bone, loose body, excuse me. You see those arrows there? Okay, you would agree that the one on the left is the medial epicondyle, right?
Yes.
Okay, why? Because it's that big bony prominence we talked about yesterday, right? So if this is not the big bony prominence, then this is the lateral epicondyle, correct? Okay, do you think we might treat this one on the right-hand side differently? Yes. If that piece is big enough, we may have to do something about that. Because remember we talked about loose bodies can kind of, depending on where they are, they can float in places and cause mechanical symptoms. Right, so we may have to do something about that. So if the picture is unclear though, then you can get an MRI to gauge both the diagnosis and the severity. Okay, do we get a lot of MRIs for epicondylitis? No. Usually, and we'll talk about this, usually after we do a lot of therapy. Okay, a lot. It's kind of like that mindset of, excuse me, when I talked about multi-directional instability. You know, somebody comes in and says they have multi-directional instability, PT, they come back and I say more PT, they come back and I say more PT, and then finally I say uncle, and I get an MRI and we'll talk about surgical options. Maybe the surgical options aren't necessarily the best. Okay, if you don't do anything about it, persistent pain, weakness, obviously poor endurance, right, so they're not able to perform in the activities they're trying to engage in, you know, to the level that they're satisfied. So, can you have a rupture? Yes. Of the flexor pronator mass or extensor mass, depending on which side it is, correct? Medial lateral. If it's bad enough, you could get a rupture. Incidentally, do you think you could get a rupture if you're doing multiple steroid injections in the wrong places?
Yes.
Yes. We'll talk about that. But this is important to understand. Now we're summing up both medial and lateral together. See how the slide changed? Now it just says epicondylitis treatment. Okay, so again, the mainstay is physical therapy. Okay, and then what percentage is a good result with just non-operative care? NSAIDs, rice, attenuation modification, And then it says occupational therapy in yellow there. This is kind of the first time we're talking about this, correct? So when it comes to occupational therapy, they tend to be really good at elbows, wrists, and hands. Okay, those are kind of the elbow, wrist, and hand people. Some shoulder, not all occupational therapists do shoulder, but some do. But they are the people that we send, when I was working in hand surgery, we send them to OT. So don't let that throw you off, okay? OT tends to be more of the elbow stuff. You okay with that? I wanted to bring that up. So 95% though for lateral epicondylitis and 85% for medial epicondylitis. Strap, that's that right there. Has anybody ever worn this strap? Well, nobody missed anything, right? But I have. Okay, so what does that do? So if you're looking there, that's a lateral, correct? Is that the ECRB? Okay, so is it? Yes, okay, good, it is. So when you're talking about that, so therefore it goes all the origin's all the way at the lateral epicondyle, correct? So what you're doing by using that strap is you're changing the working length of that ECRB. Okay, so, and also providing compression. So those straps can help. Most clinics don't have them. But as I found out, Walmart does. Okay, they're about 20, 30 bucks. But they do help, okay? So corticosteroid injections, if symptoms persist, in which epicondylitis? Is medial and lateral you're going to stick needles in and around the elbow? Not medial, okay? Unless you want to twang on the guitar string called the ulnar nerve and get kicked in the face a couple times, because that hurts. So don't go sticking needles in and around the medial epicondyle, okay? So non-operative treatment failure, then we go on to debridement. It's literally hocus pocus surgery sometimes. You go in there, you make an incision, you look at it, you say, I don't see anything. I don't really see anything. And then we kind of like muck it up a little bit and debride a little bit of what may look a little angry. And then we get the heck out of there. Because do we want to cause a change in the origin?
No.
No. So we're not actually going to do a takedown, if you will. That's what that's called. When you take it down, you basically detach it completely from that anatomical landmark. We don't do that. A lot of times we just do a debridement. So again, it's like, high five, you know, $3,000, good to go. Okay? But just so I will tell you this, if you haven't sent the physical therapy yet, when you send a consult to me, I'll see them. But guess where I'm going to send them? Physical therapy. And then when they come back, physical therapy. And if symptoms are bad enough, I'll do a steroid injection, okay, for lateral epicondylitis. Not multiple though, because does that put them at risk of rupture?
Yeah.
Okay, that's it. That's our entire discussion about that topic. Okay? Attenuated rupture of adjacent collateral ligaments. Okay? Basically what that means is attenuation is an intensification, correct? So you're intensifying the effect of producing a rupture. That's all that's saying. So there's that suspected nerve involvement. So if we're talking about nerve involvement, remember we're operating around the elbow, right? So say it's medial epicondylitis, but you're like, I don't know, it might be ulnar nerve entrapment. Is that an example? Yes, it is, right? Okay. That's it. Any questions about that? Okay, olecranon bursitis, you're probably, after my lecture, you're going to be like, I'm never going to treat this at all. I'm going to send all of these to Orhto. That's fine. Give me a call. I'll talk to you about it. And I'll tell you the story. So, olecranon bursitis, by definition, is inflammation of the bursa around the tip of the elbow, correct? We differentiated that yesterday in lab. That's the tip of the elbow, okay? So, it's inflammation though. Is it necessarily infection? No, okay? But it is a susceptible area, right? Because it's very thin. If everybody touches the tip of their elbow, you can get the bone pretty quick, right? Not a lot of skin there, okay? So if people have acute trauma, sometimes they'll have the trauma. It'll go on to heal the initial wound, right? It'll scab over, but they can have a resultant inflammatory versus infectious process after it heals over, okay? But you want to know history. Do they have a fall directly onto the elbow? Or do they do activities that require them to be on the elbows a lot? Spotters, right? Shooters, right? Spotters. People that are activities that cause them to do a lot of stooping on their elbows, right? So that's that excessive propping there. So it's excessive leaning on the elbows. Okay, I've seen that with gardening. I don't know why people get in the F1 position when they're gardening, but I've seen it with gardeners. Apparently they got there in the I don't know, rose bed or something on their elbows a lot, and I'm like, I don't know. This is not why they sell those pads, right? I don't know. But that's one thing I've seen too. But it's that excessive propping up on the elbows, okay? All right, so what other conditions can it mimic? Remember we talked about in gout, you can have tophi, correct? In RA, you can have those nodules, right? So that's in your differential. Chondrocalcinosis, well, that could be anywhere, correct? So we talked about that more so in knees, but you can have that in the elbow too. But everybody sees the inflammation of the bursa there, right?
Yes.
Very thin skin there, right? So you can take that skin and pull it pretty far out, correct? So could it be pretty pronounced on clinical exam?
Yes.
Yeah. Look at that. Does that look nasty and angry? Yeah. It looks like almost like there's a larvae coming out of it, right? All right. So that's something you may see. Okay. So when you're talking about clinical symptoms, you want to know, was it just a gradual onset, so it leads you to think it's been chronic, or was it an acute process that occurred, some kind of acute trauma, okay, that they can actually say on this day this happened. Make sense? So that's kind of how you start working your way down. Do they have limited range of motion after an acute injury, or if you believe that infection is present? We talked about infection already, right, when it comes to joints, septic arthritis. Right, but if that elbow is big and inflamed and angry and purulent, right? The word is purulent. Don't say the other word, right? Because we don't use the other word. Spell it out. Understand why you don't use that. But if it's purulent, then they're going to have limited range of motion, correct? Especially in terminal flexion. Make sense? Everybody do that. It feels kind of tight when you do that, right? So they're not going to want to do that. So they're going to walk around kind of in this arm bent position like this, you know, or just completely down on their side. Make sense? If you feel a firm lump, you want to understand, is that something that was because of the inflammatory process and it's kind of scarred in? Or is this something that, you know, maybe something else? Can you get tumors in and around the elbow?
Yes.
You can. So again, your differential should be based on what you feel is going on. We talked about the gouty stuff, right? So, but when you're talking about these gouty tophi or nodules, those tend to be much harder than scar tissue, right? Scar tissue tends to still be somewhat mobile and squishy. Okay, I don't know how else to describe it, but I wish I could tell you the difference between a RA nodule, but you're just going to have to see it in clinic. Okay, but RA nodules are nice and firm. Okay, so look at that elbow there. Top one is supposed to denote chronic, and the bottom one looks angry, right? It looks like it wants to scream at you or express purulent material from there if you were to stick a needle in there or just nick the skin, right? That looks angry. So what you're looking for is there any breaks in the skin, right? Is there an abrasion or laceration from some form of trauma? How big is it? How big can they get? Pretty big, right? Right? And that size will come into play here in a second. I don't want to minimize that because you're going to want to know that soon, right? But if it's red, hot, and swollen, it's always infected unless otherwise proven, correct? The answer is yes. So exquisite tenderness. When you hear that word exquisite, and when someone says exquisite tenderness, right? It sounds funny, but when we use that term in orthopedics, that means we're thinking it's something bad, right? Red, hot, swollen with exquisite tenderness and a traumatic origin, right? Recurrent is usually less tender. Over time, again, like I discussed earlier, it can kind of scar it a little bit, and it can still look, you know, large or medium size or even small, but it's just something that bothers them, especially when they go to put pressure on their elbows. Make sense? Do you think someone on the bottom right there is going to want to put pressure on that?
No.
No. That looks juicy. Okay. Juicy. Okay. So radiographs, you're always going to get that, especially if there's a history of trauma, correct? Can you have olecranon fractures?
Yes.
100%. And those, by rule, are sure to go into otherwise proven. Is the ability to extend your elbow important?
Yes.
Yes. So if it involves the triceps insertion, right? You got to do something about that. You got to be able to get change to the Burger King drive-thru. I hate Burger King. I don't know why I use that example. So soft tissue swelling. Can you see the angry jelly? Oh, I mean, I shouldn't use the word jelly, right? But the angry, juicy looking protuberance there of soft tissue. You can see that there, right?
Yeah.
So laboratory. Here's where I get on my soapbox. All right. You see this, right? And you're not 100% sure how to do an aspiration of this. Don't do it. Okay? Because remember, this is supposed to be superficial, correct? So if you go through the superficial nature of this, right, and you end up in the joint, did you just introduce bacteria into the joint?
Yes.
Okay? You did. All right? And so that's a risk when we tell people, it's like, when you're going to do an aspiration, and you think you know what you're doing, you get one guy, right? Or lady, please. Thank you. Because you get one. Because if you don't, if they come back and the clinical picture doesn't improve, now we got to rule out that they don't have an infection. Correct? So Station Okinawa, the only orthopedic surgery PA for 5 surgeons in the entire Pacific Rim and that area, whatever. All the fleets and all this craziness. Get a call. Flight doc, I'm not making fun of non-residency trained physicians, okay? But he called me and said, hey, I did an aspiration a couple weeks ago for suspected bursitis, and now the patient's presenting with fevers and all this kind of craziness, okay? I'm going to shorten the story a little bit. He went on to become septic, never regained consciousness. We washed him out multiple times, made an incision from right about here all the way up to his shoulder, and kept doing washout after washout after washout. He got the bad stuff. What's the bad bacteria that you get? Necrotizing fasciitis. It went from a superficial little thing into his joint, into his system, all his upper extremity. I literally, when I closed him up, when we finally medevaced him after about a week at Okinawa, I just did a running suture just to bring it like a lace, right? Just to lace it back up a little bit because they're gonna have to pop it again when it gets to the other side. All right? But it was the longest closure I had done up to that point. It was crazy. Okay? Japanese surgeons were like, "Oh, you're a very skilled surgeon." They had no idea what I was doing. It was my first duty station. Right? But basically, the point of this story is, you can take something that's very, very minimal and make it very, very bad. Okay? You guys know what an M&M is? Yeah, that conference. Ooh, I've never seen somebody sweat so hard at an M&M. So again, can you do an aspiration for diagnostic and therapeutic purposes? You can. But remember, if you're doing it for therapeutic purposes, make sure you know what you're doing. Good to go? Rant over. Okay? So what can happen if you just let it go? So it can get chronic pain, obviously. Secondary infections. Okay? Can that bursitis that's infectious in nature travel elsewhere? 100%. Right, we talked about looking for seeding, right? When it comes to osteomyelitis. Okay. Decreased range of motion and a chronic draining wound. Okay? So non-operative, I want you guys to focus on these words. Right? See how the top one, I even put them in yellow and underlined them. Okay? That's all I can do besides answering the question for you. Okay? Small mass, mild symptoms, large symptomatic bursa, and then septic. Know these differences, okay, guys? Okay, so small mass, can you do a lot of conservative care for small masses?
Yes.
With mild symptoms, you can. You see that wrap process there? Is compression good?
Yes.
Yes, right? So it's part of rice, right? So you can do that wrap there, that's there, right? Okay, that's good. But you won't be doing this part at the bottom right, right? That's me cutting into someone's elbow. Okay? So, if you think it's septic, send it. Don't play with it. Okay, good to go? Right. See that right there? This is adverse outcome of treatment. So we drained it, right? We did a debridement. We like to use the word debridement a lot. It sounds fancy, but it sounds like we're actually doing something, right? We're just mucking things up and taking things that look not healthy out, okay? So after you do all that and go on to not heal it, right? They have a chronic draining wound, we can do revision surgeries. You see how it looks like we took that flap, that open area there, and put something around it, kind of close it up a little bit, right? We probably got that from his butt cheek. okay? Or some other form of part of his body that didn't require as much coverage, okay? Or we used, I didn't do this one, but you used some tissue from somewhere else, okay? But even after having said that, they can still have a chronic recurrence. Make sense? Okay? And it may not necessarily be bursitis, but it still could be a non-infectious in nature. Okay? All right. So what's your main thing to take away from this? If you think it's infected, send it, right? Especially if you've done multiple aspirations, which I hope you never get to that point. Right? I know I'm lecturing off topic a little bit, but just send it, okay guys? All right, until you feel comfortable. No, all right, so we're gonna move to nerve compression syndromes. This is another one where you're like, oh man, more nerves, right? Good Lord, and it's not. So I did, again, take this slide and break it up for you guys. 3 main areas to focus on, okay? 3 main areas to focus on. Ulnar nerve, radial nerve, median nerve. We know about this, correct? We know that there's different distributions. That picture there is supposed to denote kind of where they run when the arm is in the, excuse me, the elbow is in the anatomic position, correct? Do those positions change when they flex? They do, correct? Okay. So again, this is in the normal anatomic position. Understand when we talk about nerve, then we start talking about other terminology. So ulnar nerves are cubital tunnel. Radial nerves are radial tunnel syndrome. Okay, and then median nerve is pronator syndrome. So know these 3 differences, guys. Okay, take some time with this slide. I see people highlighting, right? Because it's important to understand these differences, okay? So remember we talked about those distances in the elbow when it comes to certain pathology? All right, so ulnar nerve, do you think sometimes when there's cubital tunnel syndrome, you may confuse it, kind of in the clinical picture, with medial condylitis? Yes, right? So, but understand it can be compressed in multiple sites, right? So the most common being 10 centimeters proximal to 5 centimeters below the elbow. Is that at the medial epicondyle? No, that's further away, correct? Either proximal or distal. So this will may have a little bit of a different presentation, okay? Radial nerve, PIN compression, okay? Posterior intraosseous nerve, right? Is that a branch of the radial nerve? Yes. And I'll show you a picture here. I'll give you guys a picture. So when we're talking about that, is the radial nerve on the ulnar side or the radial side? Radial side, okay? So I'd say that to kind of tell you when you're taking a test, right? I expect to see people doing the waiter step, right? And I expect people to see people flexing and doing the middle finger resisted and all that stuff. So if you guys get thrown off by this, you know, while you're taking the test, you can use your own body to kind of remember, okay, this is what we're talking about. Make sense? Okay, so don't especially when you get the lower extremity stuff, I see people break as in hearing tests. Okay. So then when we get to pronator syndrome, this is the one that is very, very difficult to diagnose. Okay, pronator syndrome is something that's very vague. Okay, very vague, and it tends to have compression in the proximal forearm. Notice how I said forearm and not elbow, correct? So this is going to be more distal. So when you're talking about forearm and the patient points to you and it's almost at the mid-forearm where they're reporting pain, you know, but you take the arm and you rotate it and you say, okay, well that's on the lateral aspect, so that's lateral epicondylitis. Well, is it though? Because it's in the forearm. Make sense? Okay. How far away from the forearm, excuse me, from the elbow, can they have symptoms of lateral epicondylitis? 1 centimeter. That's the width of your fingernail. Okay, guys? So if they're pointing to the mid-forearm, what's your primary diagnosis? Pronator syndrome. Okay? So you see how I want you guys to start thinking about this stuff? Okay. So cubital tunnel syndrome, I'm not going to read to you because you guys have probably covered this already in neurology. But that's where you start talking about that distribution, but also that, what, hypothenar atrophy, right? So when you look at their hands, right, and you compare both sides, you notice that there's a little bit more atrophy in their palm compared to the unaffected side. Okay, so you have visible signs of wasting, and that's especially true if you have chronic symptoms or a chronic condition. Good to go? So once you see the wasting, it's now chronic. That's what I just said to you. So how do I tell if it's chronic? Because I see wasting. Okay. Radial tunnel syndrome, like levocondylitis, but 4 to 5 centimeters distal. There's your number. It's in yellow. Is that 1 centimeter? No. Fair game for me to ask you. But would I give you something that says like 1.2 centimeters? No, I would. It would be pretty obvious. Okay, but just key in on that. So in a pronator syndrome, which fingers are they going to have median nerve symptoms? The radial aspect of the index finger, right? See how I'm using that terminology now? We're all there, right? So the radial aspect of the index finger, correct? So once we get to the long finger or middle finger, I like to use the word middle finger, and we'll talk why next week. But once you get to the ulnar aspect of the middle finger, did you have a question? No, okay. Okay. He's locked in that position. But anyway, so the middle finger, when you're on the ulnar aspect, what nerve are you at then? Okay, good. See, we're on the same page, right? If that was foreign to you, refresh, please. Okay? Yes. You do have a question?
Would you say that the ulnar aspect of the pointer finger, that's
The radial aspect,
ulnar
ulnar aspect of the index finger?
Yes.
Which one is that?
That would still be medial, right? Or median?
Median? Is it? So are you on the dorsal aspect of the index finger or the palmar aspect of the middle finger? And are you distal or proximal? You guys will look at that chart, right? You see how tricky you can get, right? So what do we do in orthopedics? So to answer your question depends on where you are on the finger, right? So that was his question was, depending on what aspect of the finger you're checking for sensation, you cross over to a different nerve, correct? So when you look at that picture that I gave you, that you guys throw away after the test, right? You look there and you see, I gave you the picture that has both the volar and the dorsal. To let you guys know, you have to actually know where you are. Well, what's consistent with the median nerve is that if you're on the radial aspect of the index finger, that is the median nerve. It doesn't matter where you are. Are we good with that?
Sir.
So I set you up for success next year. Okay? That's a good question. Okay. So test for this, we're going to go through this in the lab next week. This we're going to hammer down. Okay? 3 tests I want you guys to understand, at least 3 right here. Okay, it's the Tinel sign. Okay? Some of you guys love using hammers as much as I do. Feel free to use the hammer for the Tinel sign. Are you going to be thumping directly on the medial epicondyle?
No.
Dude, that's not where it is, right? So right there is, and that picture is showing you. So therefore, let's skip one and get to the compression test. Now, aren't you also going to be compressing there too? Yes?
Yes.
Okay, good. So that, I've seen people just thumping on the epicondyle. I'm like, we're going to be here all day. Okay, so elbow flexion, see how they do, you guys probably taught you this, correct? And then stare at your patient for a minute. Okay, but you see how he also extends at the wrist? All right, so if you want to differentiate, sometimes you have to take away the wrist component of it. Because what's this test called? Phalanx, right? So is that phalanx? It's done like this, correct?
Yes.
Not like this, right? So the reason he's doing it like this is to take away that tension and flexion and focus only on elbow, okay? With the elbow flexion test, do you want to do maximal flexion? Yes. So you want literally them to be like this, right? And maybe not so much out like that. I think I should have done like that for picture purposes, but you want them to do maximal flexion. And a lot of times I have them actually do this. Okay, so that forces them a little bit more into flexion for whatever reason. Make sense? Okay, and how many seconds?
60.
For all the tests, correct? Excuse me. Yeah, okay? So, we'll talk about this next week. Diagnostics, EMG, right? NCS, if there's conduction issues. I can tell you right now, when it comes to ulnar nerve neuropathy, you will get an EMG, NCS, always. if we're thinking about doing surgery, that patient must get one, okay? Because we need to decide if we're doing the right surgery, right? So a reduction in velocity of 30% or more suggests ulnar nerve compression. Is that in yellow? Yes, okay. Why is that the only thing in yellow? Because when you get these study reports in the future, some neurologists are not nice people, right? They will just give you the results, and then you have to interpret it, right? So that is unfortunate, but I've seen it, okay? So you have to look at it. So then you have to say, well, what percentage am I looking at to say that it's abnormal? And you compare it to the unaffected side. If it's 30% or more in the ulnar nerve distribution, you see how this here shows both the latencies and the amplitude? Well, the report is pretty, has anybody ever actually seen an NCS? Okay, well, you have? Okay. So basically, it'll be a report that breaks it down by nerves. Okay, so you'll jump right to the ulnar nerve one, because that's what you're suspecting, and you'll look at those numbers. Make sense? Okay. Remind me, I'll bring a report in so you guys can see it. Okay. I might bring mine. So. Okay. Why do we get X-rays? We always get X-rays first, right? And also just to rule out fractures. Okay. All right. So obviously, if we don't do anything about it, you think since they have neuropathy that they can have altered sensation and decreased motor function? 100%, and pain. Okay. So this weird splinting thing on the right-hand side, have I ever done that? No. But basically, if causing the elbow to be in flexion causes your symptoms, do you think if you put an extension, it'll decrease your symptoms?
Yes.
100%. Okay. A lot of times, what I end up doing, and then when we talked about OT, I send them to occupational therapy because they're the elbow, wrist, and hand people, right? They will fashion custom elbow splints that patients wear all day or at night. Does anybody walk around like this? Right? Not unless you make them, right? But at nighttime, most people will get into that and try it. Okay? The other thing we can do is tell them to hug their pillow with the pillow straight, like this. Right? That's something that's very commonly taught, but I don't know about you guys, I can't sleep like this. Okay? So, but you may hear that. Okay? So, but otherwise, it's the NSAIDs, RICE, activity modification, and OT. I should have highlighted that, right? So OT's there. See how that's different? So we don't send people to OT for knee stuff, right? But in elbow, hand, and wrist, that's where you want to prioritize. Okay? Steroid injection is not recommended. Which side is the ulnar nerve on? Medial. So therefore, don't stick needles around there. Okay? That's no man's land. I don't do it. You shouldn't do it either. No, it's not that it's a specialty thing. So, non-operative treatment failure. So what we do basically, if there's some kind of compressive force there, maybe not force, but some kind of compressive component, we'll release that. Make sense? But sometimes we have to do a transposition. What is a transposition? We take it from where it was and put it somewhere else. That's the basis of it. Then sometimes you'll get ulnar nerve subluxation. We talked about subluxation, right? Right? So sometimes they can get what's called ulnar nerve subluxation. As you go from extension to flexion, you'll actually feel the ulnar nerve popping. And you can see it moving. We had a fellow one time that would just sit there and just do this as a party thing, right? And just have their nerve popping in and out. You know, is it painful? Right? Yeah, it's painful too, so they may report that. So if they also have subluxation, then we'll do a transposition. We'll tack it back down somewhere else. That's an anatomy discussion, but I'd be happy to answer that question. She was asking, where do we tack it down? So usually the way that it subluxates, right, depending on whether it's flexion or extension, it'll subluxate anteriorly, right? So we tend to tack it down posteriorly. Make sense? Is that good for now? Yeah, there's a lot to that. All right, so adverse outcomes of treatments. All right, so obviously anytime you splint and cause breakdown of skin, don't do that. Don't be that person. Incomplete resolution after surgery. Red flags for you guys is you've done everything you can do, and either A, you can't figure it out, right? You got the conduction studies and still doesn't make sense, or B, remember we talked about in lumbar and cervical spine, them getting worse. And once they get to a point where they have hypothenar atrophy, do you think that's an indication to refer them? Do you think any physical therapy in the world is going to help them? No, there's nerve compression. You know, they can PT to death, and that's not going to improve. Make sense? Okay. All right. Do we want to call it for today?
Yes.
Good. If you guys have any questions, let me know.